Dr. Dietz did this study looking at how we move our levator muscles with Valsalva. And he took 50 nulliparous women who were 36 to 38 weeks pregnant, and he did the pelvic hiatus pictures with and without Valsalva. He taught them how to do a Valsalva, and he found that only 22 out of 50 decreased their hiatal diatus like they were supposed to for a Valsalva maneuver. 11 out of 50 were able to decrease it after a secondary instruction, but you can see that basically many women cannot Valsalva correctly. That means that we have to teach people how to do this better. Here we have a picture on the left of at rest, where you can see the nice pubal rectalis muscle. And then on the first Valsalva, it doesn't really, it decreases instead of increasing. And then when we get an optimal Valsalva, we get our maximum extent here. So I think this was very important in confirming what many women already knew, that we didn't really know how to do our Valsalva maneuvers appropriately. We weren't doing our Kegels in a way that was actually helping us strengthen our pelvic floors. We just didn't know how. There are physical therapists that help and can put their hands in your pelvis and watch your muscles, feel your muscles, and tell you what you're doing right and wrong. And in France, every pregnant woman has appointment with a PT person to help them do their Kegels afterwards. And maybe this would decrease some of our pelvic floor incontinence if we knew how to do this. Now, the posterior compartment is also something that we use for fecal incontinence, that we can not only assess the sphincters, but we can also look for other abnormalities such as rectoceles and intussusception. And these things can be detected on ultrasound. So here you have at rest the defecography showing what the rectum looks like going into the anal canal versus with squeeze. And you can see that that angle changes. That's why everyone's interested in this angle being 90 degrees here versus 115 degrees here. So there is some degree of correlation with what this means. Here's a rectocele that you can see going up here that correlates with this defecography with the rectocele blossoming out of the rectum, which certainly comes with people who have problems with fecal incontinence. Now, this line from the symphysis pubis over to the rectum, it's that same important line we can look for cystoceles, uterine prolapse, and rectoceles. And even interoceles come down here and penetrate in, and these can be important for therapy. So here we have a patient at rest, and here's the urethra coming down, and then here we have a Valsalva, and look what happens to that bladder, that it funnels down into the tissues, and that is a cystocele. Here we have a patient who's had first-degree uterine descent after a Birch colposuspension, which is one of the surgeries they do for urinary incontinence. And you can see that here we are at rest with the bladder, and then here we are with the bladder coming down towards the cervix. Here's a rectocele, another rectocele. There's the rectum, the anal canal, and then the rectum coming out, and there it is. And here it was at rest. So that's what we look for to find a rectocele. Now, there are slightly different appearances for interocele versus rectocele. An interocele, which is from the small bowel, peristalsis, and there can be fat or momentum in it, and it usually is more homogeneous or nearly isoechoic, whereas the rectocele is filled with stool, and it often has a lot of hyperechogenicity within it with distal shadowing. So here is a typical interocele, and here's a typical rectocele in a patient that you don't see it in rest, but you do see it at Valsalva. Here's a urethral diverticulum that, now you know where the urethra is, and here is that diverticulum. And sometimes these are more easily seen on the Valsalva again. And they can simulate a cystourethrocoele, even though it's really a diverticulum of the bladder neck. Now, what can I tell you about stress urinary incontinence? Well, this is work that I've taken from the literature. I have to tell you, I haven't done a lot of work on the bladder itself. I've spent most of my research time looking at the posterior compartment. But different people are looking at the bladder for mobility and for funneling, and people are developing ranges for normal motion of the bladder neck. So here we have the bladder neck right here in this patient at rest. You can see once again the symphysis pubis, the anal canal over here, and here we have first Valsalva and then optimal Valsalva, and how much more descent there is after that. Now, the anterior compartment is where we evaluate for urinary incontinence, and Valsky talks about the height and the distance from the bladder neck and how far we go, and also the posterior urethrovesical angle in the pelvic floor. And these are numbers that they have developed at what the angle should be approximately at rest and at Valsalva. But we don't really have the abnormal numbers yet developed to figure this out. The 2D ultrasound parameters are encouraging, and we think 3D numbers would be even better, but they need to be correlated with clinical standards and dynamic studies, which hasn't been done yet. So here we have the normal pelvic floor again, and here's one of these angles, one of these distances that they're looking at in order to try to figure this out. Now here is a normal with the puborectalis muscle on either side, and then here is an avulsion with this pulling off here, and you see this ballooning out of the vagina and the space right behind the vagina here in the region of where that avulsion has taken place. Now, this is another picture of avulsion with the asymmetry that we see when we have an avulsion off the side. This is a patient that has detachment, and the question is it artifact or is it real? And this one is really just artifact. You can make a defect just by being a little bit off axis as you rotate. So you need to be able to rotate back and forth and try to get the normal picture before you're confident that it's abnormal. We do have different types of tape and surgical things that have been put in to try to help us for incontinence. So here's a nice normal picture of tension-free vaginal tape, and here's one that's kinked or broken underneath the urethra. Here another tension-free vaginal tape that you can see right here. It looks kind of like the stitches that we see with our C-section scars, and there it is on Valsalva as well. So it is in place, it's in the right place. And here's one called macroplastic injectable that is a nice normal appearance of that from the literature. So the pelvic floor, I think these are some articles that you can look up if you'd like that I think are excellent editorial or review articles to give you an idea of what's going on in the literature. And I hope that was helpful to you. And thank you very much.